I am Vivian Larian Alde Guzman, and I will present to you about Addison's disease. We are going to talk about the etiology and pathophysiology, epidemiology, signs and symptoms, diagnosis, and its treatment. What is Addison's disease? An endocrine or hormonal disorder that occurs when the adrenal glands do not produce enough of certain hormones. An acquired primary adrenal insufficiency. A primary adrenal insufficiency is termed Addison's disease when autoimmune response causes the condition. It is rare but potentially life-threatening emergency condition. It results from bilateral adrenal cortex destruction leading to decreased adrenocortical hormones which may include cortisol, aldosterone, and androgens. Addison's disease insidious course of action usually presents with glucocorticoid deficiency followed by mineralocorticoid. However, it can also present acutely, often triggered by intercurrent illness. The presentation of adrenal insufficiency depends on the rate and extent of adrenal function involvement. The most common cause of primary adrenal insufficiency is autoimmune adrenalitis, also known as Addison's disease, associated with increased levels of 21-hydroxylase antibodies. Etiology and pathophysiology of Addison's disease. Addison's disease or adrenal insufficiency is caused by an inability of the adrenal cortices to produce adequate adrenocortical hormones. Adrenal insufficiency is classified as primary and secondary. Primary insufficiency or any disease process which causes direct injury to the adrenal cortex can result in primary adrenal insufficiency or Addison's disease. Autoimmune destruction of adrenal glands is the most common cause of Addison's disease. Autoimmune destruction can be an isolated finding or autoimmune polyglandular endocrinopathies type 1 and type 2. Patients with the autoimmune adrenal disease are more likely to have polyglandular autoimmune syndromes. Type 1 autoimmune polyglandular syndrome is manifested by autoimmune polydendocrinopathy, candidiasis, ectodermal dysplasia. Classic triad also consists of hypoparathyroidism, Addison's disease, and mucocutaneous candidiasis. The type 2 autoimmune polyglandular syndrome comprises several associations: autoimmune thyroiditis, type 1 diabetes, autoimmune conditions such as pernicious anemia, vitiligo, or alopecia. Addison's disease has been reported with celiac disease. Infections of primary adrenal insufficiency include sepsis, tuberculosis, cytomegalovirus, and human immunodeficiency virus. The prevalence of tuberculosis has declined, but HIV has emerged as the most important cause of adrenal insufficiency associated with adrenal necrosis. Other infectious causes include disseminated fungal infections, histoplasmosis, and syphilis. Blastomycosis is a common cause in South America. Adrenal hemorrhage is a bilateral adrenal hemorrhages can be precipitated by disseminated intravascular coagulation, trauma, meningococcema, neoplastic processes. Infiltration. The adrenal infiltration occurs in hemochromatosis, amyloidosis, and metastasis. Other causes include sarcoidosis, lymphoma, and genetic disorders such as congenital adrenal hyperplasia and adrenal leukodystrophy. Certain drugs can cause adrenal insufficiency by blocking cortisol synthesis. Ketoconazole inhibits adrenal enzymes. Etomidate selectively inhibits 11-beta hydroxylase, which converts deoxycortisol to cortisol. The effect of etomidate is dose-dependent. Secondary adrenal insufficiency. Secondary insufficiency occurs most commonly due to exogenous steroid administration resulting in the suppression of adrenocorticotropin hormone synthesis. It is a pituitary-dependent loss of ACTH secretion, which results in a reduction of glucocorticoid production. However, mineralocorticoid secretion, including aldosterone, remains at a relatively normal level. It is more common than primary insufficiency. Symptoms usually occur after discontinuation of the steroid. Primary autoimmune-mediated intrinsic adrenal gland dysfunction, both cortisol and aldosterone deficiency. Secondary chronic glucocorticoid administration resulting in hypothalamic pituitary dysfunction, only cortisol deficiency. Epidemiology. Addison's disease is rare. The incidence is 0.6 per 100,000 of the population per year. The total number of people affected by this condition at a given time ranges from 4 to 11 per 100,000 of the population. In adults, the common age of presentation is 30 to 50 years. It is more common in women. Here are some risk factors for the most common type of autoimmune like Addison's disease, including other autoimmune diseases. Type 1 diabetes, hypoparathyroidism, hypopituitarism, pernicious anemia, Graves' disease, chronic thyroiditis, dermatitis herpetiformis, vitiligo, myasthenia gravis. Here are signs and symptoms of Addison's disease. Extreme fatigue, weight loss and decrease in appetite, darkening of your skin or hyperpigmentation, low blood pressure, even fainting, salt craving, low blood sugar or hypoglycemia, nausea, diarrhea or vomiting, which are also gastrointestinal symptoms, abdominal pain, muscle or joint pains, irritability, depression or other behavioral symptoms, body hair loss or sexual dysfunction in women. Here are some illustrations of other signs and symptoms of Addison's disease. The hyperpigmentation of the skin and the oral hyperpigmentation in the mouth. Diagnosis for Addison's disease. Your doctor will talk to you first about your medical history and your signs and symptoms. You may undergo some of the following tests. Complete history collection and physical examination. It performs a physical exam. The dark patches on your skin might be a clue for your doctor to consider testing for Addison's disease. Assessment serum electrolyte levels, potassium and sodium levels. Blood tests. Tests can measure your blood levels of sodium, potassium, cortisol, and adrenocorticotropic hormone, which stimulates the adrenal cortex to produce its hormones. A blood test can also measure antibodies associated with autoimmune Addison's disease. ACTH stimulation tests. ACTH signals your adrenal glands to produce cortisol. This test measures the level of cortisol in your blood before and after an injection of synthetic ACTH. X-rays. This may be done to look for calcium deposits on the adrenal glands. CT scan or computed tomography scan uses computers to combine many X-ray images into cross-sectional views. A CT scan might be done to evaluate the adrenals and or pituitary gland. For example, it can show if the immune system has damaged the adrenal glands or if the glands are infected. Treatment for Addison's disease. All treatment for Addison's disease involves medication. You will be given hormone replacement therapy to correct the levels of steroid hormones your body isn't producing. Some options for treatment include oral corticosteroids such as hydrocortisone, Cortef, prednisone, or methylprednisolone to replace cortisol. These hormones are given on a schedule to mimic the normal 24-hour fluctuation of cortisol levels. Fludrocortisone acetate to replace aldosterone. If patient also lacking aldosterone, fludrocortisone acetate pills will be provided. If patients are taking fludrocortisones, they need to increase salt intake, especially in hot and humid weather and after exercise. In emergencies and during surgery, the medicine is given intravenously or directly into a vein. And most importantly, stay in contact with your doctor to make sure that the doses of replacement hormones are adequate but not excessive. For potential future treatments for Addison's disease, researchers are working to develop delayed-release corticosteroids which act more like the human body. They are also working on pumps implanted under the skin that can deliver steroids in more accurate doses. Future treatment may eventually involve using adrenocortical stem cells combined with immunomodulatory treatment, modifying the immune response or the immune system, as well as gene therapy. Thank you for listening.